Hello there. I go by the name Dr. Samuel Kozize, and today I'll be talking about the principles of fracture management. And I'll be using the following outline, including introduction, epidemiology, goals of management, classification, basic principles of fracture healing, pre-hospital care, primary survey, secondary survey, investigations, treatment, complications, and conclusion. By way of introduction, a fracture is defined as a break in the structural continuity of a bone. It occurs when a force in excess of the breaking limit of the bone is applied to it. Fractures can result from injuries, repetitive stress, or abnormal weakening of the bone. Epidemiologically, fractures are among the commonest traumatic injuries worldwide. They have a bimodal mode of distribution, one in young adults and the other in the elderly. In young adults, high energy trauma, such as road traffic crashes, falls from height, sports, and violence are common, while in the elderly, low energy trauma due to osteoporosis is a common cause. Now, males predominate in the younger age group, while females predominate in the older age groups. Now, the goals of management include prompt stabilization of the patient, restoration of anatomy, restoration of function, and prevention of complications. Fractures generally are classified as closed and open fractures. Closed or simple fractures refers to fractures which do not communicate with the exterior. On the other hand, open or compound fractures are fractures which communicate with the exterior through an open wound. The significance of this broad division is that open fractures are contaminated ab initio, and if not promptly treated, infections set in. The Gustilo-Anderson method of fracture classification is used to further subclassify open fractures into types 1, 2, and 3. Type 1 fracture refers to an open fracture with a puncture wound less than or equal to 1 centimeter with minimal contamination and minimal soft tissue damage, while type 2 refers to a laceration more than 1 centimeter but less than 10 centimeters with moderate soft tissue damage, adequate bone coverage, and minimal comminution. Type 3A refers to a laceration more than 10 centimeters with extensive soft tissue damage, adequate bone coverage, and segmental or severely comminuted fractures or heavily contaminated wounds. Type 3B refers to a Gustilo-Anderson type 3A injury, but with periosteal stripping and bone exposure. This type of injury will require flap coverage to provide soft tissue coverage. Type C refers to any open fracture with arterial injury requiring repair. Complete fractures are those in which the bone is split into 2 or more fragments. Incomplete fractures are those in which the bone is incompletely divided and the periosteum remains in continuity. Displaced fractures are those in which the 2 ends of the fracture are significantly out of their normal alignment, creating a gap in between. Undisplaced fractures are those in which the fracture pieces remain in their proper alignment. Other types of fracture classifications include pathological fracture, which is a fracture that occurs through a diseased bone, usually caused by a trivial force that will not cause fracture in a normal bone. The bone can be weakened due to osteoporosis, osteogenesis imperfecta, Paget's disease, bone cysts, or cancer metastasis to the bone. A stress or fatigue fracture is one which is due to repetitive stress on a normal bone and is seen commonly in athletes, dancers, and army recruits. It involves the metatarsals most times, but can affect any bone. Comminuted fractures are fractures which have two or more fragments in the same fracture site, while segmental fractures are those that have two or more distinct fracture sites in the same bone, usually a long bone. A greenstick fracture is one in which the bone is not completely broken, but is bent or buckled like a snapping green twig, usually seen in children because of the springy nature of bone at that age group. Impacted fractures are those in which the fracture ends are interlocked, and is common in cancellous bone and at the end of long bones, while compression fractures refers to where a fractures where the bone is crushed or squeezed into itself. It is seen especially in cancellous bone. Examples include the vertebral bodies of the spine. Transverse fractures are those occurring in a straight line perpendicular to the long axis of the bone. It is usually caused by a direct blow or high impact trauma. Oblique fractures are fractures in which the fracture line runs diagonally across the bone, typically occurring in long bones like a femur or tibia from angled impact or twisting forces, while spiral fractures refers to fractures in which the fracture lines wraps around the bone in a corkscrew or spiral pattern caused by a twisting or rotational force. Another system of classification which categorizes pediatric fractures involving the growth plate, that is the feces. It divides fractures into 5 types using the mnemonic SALT R as a guide. Type 1 refers to fracture through the feces, while type 2 refers to a fracture through the feces and metaphysis. Type 3 refers to a fracture through the feces and the epiphysis. Type 4 refers to fracture through all 3 structures, including the epiphysis, the feces, and the metaphysis. While type 5 refers to a crush injury around the feces or growth plate. This classification helps to predict the risk of growth disturbance, with types 1 and 2 generally having good outcome, while types 3, 4, and 5 have poorer prognosis and may need surgery. For the basic principles of fracture healing, it's worthy of note that the process of fracture healing or repair varies according to the type of bone involved and the amount of movement at the fracture site. The first type of healing is referred to as healing by callus formation. This is the natural form of healing in tubular bones, and it happens in the absence of a rigid fixation. It proceeds through 5 stages. The first stage is tissue destruction and hematoma formation, followed by inflammation and cellular proliferation. Then callus formation, which refers to fibrous tissue and cartilage. Afterwards, the callus is consolidated, whereby the callus is transformed into lamellar bone. And then over time, there is remodeling by reshaping by a continuous process of alternating bone resorption and formation. The other type of bone healing or repair, healing by direct union. In this case, if the fracture site is completely immobile, there's no stimulus for callus formation. So instead, osteoblastic new bone formation occurs directly between the fragments. Gaps between the fracture surfaces are invaded by new capillaries and osteoprogenitor cells growing in from the edges, and a new bone is laid down on the exposed surface. This is called gap healing. So by 3 to 4 weeks, the fracture is solid enough to allow penetration and bridging of the area by bone remodeling units, that is the osteoclast and osteoblast. For the pre-hospital care of fractures, there is need for prompt recognition of injuries, and this goes by the way of the advanced trauma life support protocol. The life-threatening injuries are first assessed for immediate intervention, administration of intravenous fluid, and even blood transfusion can be given if necessary at this time, while rapid transfer to an appropriate level trauma center should be performed in the safest and possible shortest time. The primary survey using the ATLS protocol involves ensuring airway patency and cervical spine stabilization, followed by assessment of breathing, which is done by having a quick chest examination to identify any life-threatening chest injuries and also to ensure adequate ventilation. Under circulation, the pulse and pulse pressure are checked, and any possible hemorrhage sites are located and controlled, and two wide bulb cannulae are used to secure intravenous access to commence intravenous infusion, and at the same time, blood samples are taken for investigations including hemoglobin, serum electrolytes, urea, and creatinine, grouping and cross-matching, as well as fasting blood sugar. Disability and neurological status is where the consciousness level of the patient is assessed, either using the Glasgow Coma Scale or the AVPU method. As for the exposure, the patient's clothing are removed to look for any hidden injuries which might not have been discovered before now. Also, the patient is covered to prevent hypothermia from occurring. For the secondary survey, a detailed history is taken, including patient's biodata, as well as the ample history, which encompasses allergies, medications, past medical history, last meal, as well as events leading to presentation. The mechanism of injury is also important, and symptoms of associated injuries, including head, chest, abdominal, pelvic, as well as spinal injuries, are elicited, as well as life-threatening conditions related to fractures, such as hemorrhage. As for physical examination, it begins with the general examination, where the surgeon must assess the general clinical state of the patient for any form of distress, evidence of blood loss, head injury, spinal or visceral injuries. Also, the musculoskeletal examination following the usual look, feel, move format, beginning with inspection, where the injured site is inspected for swelling, bruising, wounds, and deformity, which may be obvious. However, the important point is to check if the skin is intact. The injured part is gently palpated for localized tenderness, temperature, and loss of function. The common and characteristic associated injuries should also be felt for, even if the patient does not complain. For example, an isolated fracture of the proximal fibula should always alert the surgeon to the likelihood of an associated fracture or ligament of the ankle. And in high energy injuries, the spine and pelvis should also be examined. Vascular and peripheral nerve abnormalities should also be tested. The active movement in the distal joint should also be tested by asking the patient to do the normal movement of the joint. Then passive movement is done, and crepitus and abnormal movement may be present. As for investigations, X-ray examination is mandatory and it follows the rule of twos, including two views, that is, the anteroposterior and the lateral view. This is because a fracture or dislocation may not be seen on a single X-ray film, and so two views must be taken. Two joints, that is, the joint above and the joint below the fracture, must both be included in the X-ray film. Also, two limbs, for example, in children where the immature epiphysis may confuse the diagnosis of a fracture, and so X-rays of the uninjured limb is needed for comparison. Two injuries. Severe force often causes injury at more than one level, and so with fractures with the calcaneum or femur, for instance, it is important to also X-ray the pelvis and the spine. Two occasions. Some fractures are notoriously difficult to detect soon after injury. However, another X-ray a week or two later may show the lesion. Special imaging techniques may also be used, sometimes where the fracture is not apparent on a plain X-ray. Computed tomography may be helpful in lesions of the spine or for complex joint fractures. Indeed, these cross-sectional images are essential for accurate visualization of fractures in difficult sites, such as in the calcaneum and the acetabulum. Magnetic resonance imaging may be the only way of showing whether a fractured vertebra is threatening to compress the spinal cord. Another imaging modality, the radio-isotope scanning, is also helpful and is used in diagnosing a suspected stress fracture or under undisplaced fractures. Of course, other investigative modalities include a blood workup, including hemoglobin genotype, fasting blood sugar, doping and cross-matching, and urinalysis as covered within the ATLS protocol. The principles guiding the treatment of fractures have an orderly sequence of 4 Rs, that is, resuscitation, reduction of the fracture, retention of the fracture, and rehabilitation of the patient. Under resuscitation, this is usually done simultaneously with initial evaluation of the patient and entails focusing attention on the patient as a whole and not just on the fractured part. It entails quick assessment of the patient's airway, breathing, circulation, disability, and also exposing the patient. That is the ABCDE of resuscitation according to the ATLS protocol as earlier stated. Note that for all open fractures, no matter how trivial they may seem, they must be assumed to be contaminated, and so it is important to try to prevent them from becoming infected. And there are 4 essential interventions that must be done for all open fractures, including antibiotics and tetanus prophylaxis. There's also need for urgent wound and fracture debridement and irrigation, stabilization of the fracture, as well as early definitive wound cover. The next R is reduction. Reduction means putting the fracture fragments into alignment. There are basically 2 methods of reduction, including closed and open reduction. Under closed reduction, reduction can be achieved mainly by manipulation. Sometimes traction can be employed. Open reduction of fractures entails the realignment of fractured segments under direct vision through an operation. It is indicated when there is failure of closed reduction and when accurate alignment is critical, either for function, as in fractures involving articular surfaces, and also for cosmesis, as in facial fractures. In fractures in which natural traction on the fragments hold them apart. Examples include fractures of the patella or the olecranon process. Another indication is when closed reduction ab initio is not possible. Examples include intracapsular fractures of the neck of the femur. The third R refers to retention of the reduced fracture, and the aim is to prevent redisplacement, to restrict movement of the fragments in order to encourage healing of the fracture, and also to allow free movement of the unaffected parts of the body. The available methods include: number one, cast splintage. Cast splintage is ideal for stable distal limb fractures and for most fractures in children. Plaster of Paris or Scotch cast or any other cast can be used. And for effective immobilization of a fracture, the joints above and the joint below must be included in the cast. And the complications of cast splintage include tight cast, which may lead to compartment syndrome in the limb, pressure sores at bony prominences, as well as joint stiffness. The treatment for tight casts and initial treatment for compartment syndrome is to split the whole limb of the cast anteriorly down to the skin and mild elevation of the limb. In pressure sores, the cast is either split or a window is created over the bony point. Another method of the retention of a reduced fracture is continuous traction, and it is useful for shaft fracture that are unstable, as in oblique and spiral fractures, and also where the pull of strong muscles need to be overcome, as in the thigh and in the trunk. Traction may be by gravity, example as is applicable in humeral fractures when a collar and cuff are used to support the fractured limb at the wrist, and the weight of the limb up to the fracture provides continuous traction by gravity. Traction may also be by skin traction. This, however, has a limitation of accumulating only 4.5 kilograms of maximum weight. Another is by skeletal traction, where a pin is passed under aseptic conditions through a bone distal to the fracture. This has the advantage of taking any weight necessary to overcome any muscle pull. However, this has a setback of pin tract infection. Another method of retaining a reduced fracture is functional bracing. In functional bracing, the casts are applied to cover only the length of the shafts of unit bones. They are connected one to another at the joint level by hinges incorporated in them on either side, leaving the joint free to move. It is called functional bracing because of this movement allowed at the joint. The aim is to prevent joint stiffness, which is the major setback in ordinary cast splintage. However, the functional splintage has a limitation of not being rigid and therefore cannot provide adequate splintage at the early phase of the fracture during the acute period. Another method of retention of a reduced fracture is internal fixation. This is usually applicable almost whenever open reduction is done. The main indications include: 1. Fractures that cannot be reduced except by operation. An example is intra-articular fracture. Another indication is fractures that are inherently unstable and prone to displacement after reduction. An example is mid-shaft fractures of the forearm. Also, fractures that are liable to be pulled apart by muscle action. Example, transverse fractures of the patella or the olecranon process. Also, fractures that unite poorly. Example, intracapsular fracture of the neck of femur. Also, multiple fractures in which early fixation reduces the risk of general complications. Also, fractures in patients who present nursing difficulties, as in paraplegic patients, as well as the elderly and multiply injured patients. Also, in pathological fractures because of the poor healing of the diseased bone. As for types of internal fixation, they include the interfragmentary screws. Examples include lag screws. Also, you have wires. Example, sacrilege, tension bands, and transfixing wires. Another is intramedullary nails. Examples, Kirschner nails, lotus nails, and lost pin, among others. We also have plate and screws. Another method of retention of a reduced fracture is external fixation. In this method, the fracture is held by transfixing wires or pins which pass through the bone above and below the fracture, and they are then connected to an external rigid frame. And indications for external fixation include open fractures, which are associated with severe soft tissue injuries, for which the wound needs to be left open for regular dressing and inspection. Also, in fractures associated with nerve or vessel damage that need repair, to provide stabilization for the repaired tissue. Another indication is severely comminuted and unstable fracture, which need to be held out to length until healing commences. Also, in infected non-union, which needs to be excised, compressed, and packed with bone grafts to achieve infection control and bone healing simultaneously. Also, in fractures of the pelvis, which often cannot be controlled by any other method. Another indication for external fixation include severe multiple injuries in which early stabilization reduces the risk of serious complications. The last R of fracture management is rehabilitation, and the aim is to restore function to the fractured limb in particular and to the patient as a whole. The objectives are to reduce edema, to preserve joint movement, to restore muscle power, and to guide the patient back to normal activity. This is achieved by elevation of the injured part, which helps in reducing edema and therefore stiffness. Exercises, both active and passive joint movements, and muscle strengthening activities, and also encouragement of early functional activity. Complications of fractures include general complications such as acute blood loss, which can lead to hypovolemic shock, disseminated intravascular coagulation, fat embolism, deep vein thrombosis, pulmonary embolism, adult respiratory distress syndrome, multiple organ failure. Local complications could be early or late. The early complications include soft tissue damage to skin, viscera, vascular injury, or nerve injuries. Others are hemarthrosis, compartment syndrome, fracture blisters, plaster sores, infections such as tetanus, gas gangrene, and osteomyelitis. Late complications include joint stiffness, bed sores, delayed union, malunion, avascular necrosis, growth disturbances, tendon lesions, nerve compressions, joint and muscle contractures, joint instabilities, muscle atrophy, and osteoporosis. In conclusion, Successful fracture management requires a systemic and patient-centered approach. Early assessment, accurate diagnosis, and appropriate stabilization are critical. Restoration of anatomy, function, and early mobilization are key goals. Optimal outcome depends on timely intervention and complication prevention, as well as multidisciplinary care.